Okay, thanks. Thanks to the organizers for inviting me to give a talk. I'm just going to discuss some benefits on photon counting CT, technical benefits of a new type of CT technology made by Siemens, essentially, in this case. Traditional CT detectors are run on what's called energy integrating modes. So essentially what you have is a scintillator, which is a solid state scintillator, which essentially converts the X-ray photons into light. That light is then detected by some photodiodes that you see there in orange. And this is called an indirect conversion. So the energy is integrated during the measurement time of one projection, and all this energy information is lost as the signal is combined, which is what we call an energy-weighted cumulative signal. New types of technologies such as photon counting CT do not require the intermediate step of generating light. Instead, they directly convert X-rays to an electrical signal which we use to create an image. There's also an energy dependence of photon counting X-ray impacts. Low energy X-rays produce small amounts of charge, and high energy X-rays produce more charge. So the difference is that with the elimination of intermediate step of generating light, we can measure each individual X-ray and therefore their energy. This allows us to have spectral information without any dedicated scan modes or any extra technology, so there's no need for dual source, dual energy, or fast KV switching or dual layer detectors. So essentially, what I'll try to talk about very quickly is four technological advantages of photon counting detectors. And the first one is that the detector pixels can be much smaller. So essentially, we have on this particular scanner made by Siemens is a large pixel of 0.4 by 0.4 millimeters, which can then be subdivided down into 0.2 by 0.2 millimeters, which gives us an in-plane resolution of 44.3 line pairs per centimeter, which is really, really good. And I'll show some images about that in a little bit. The next is that we can eliminate electronic noise because we can apply a digital threshold. So essentially, we know what energy these photons are. And if they're above a certain threshold, we count them. If they're below a certain threshold, we don't count them. So that way we can eliminate electronic noise from the images. The third is that we have spectral sensitivity. So these pulses can be sorted into 1 or 4 energy bins, depending on what way we want to make the image. The detector always acquires the spectrally resolved signal, regardless of scan speed or temporal resolution. So it's a bit different from traditional dual energy. And the last is equal energy contribution. So the detector response is consistent with energy, unlike energy integrating detectors, where you do not have a consistent response with energy. So the lower energy X-rays count less in traditional EID. So with photon counting, you can see the orange line there. It's a bit more consistent in terms of the energy. A very quick case study that we found at MUSC in Charleston. This was a very large patient of 410 pounds, a BMI of 63, scanned over a period of 3 months for an ovarian mass. This is a scan from a Somaton GoTop. So you can see it's quite a poor, noisy image because of the patient's body habitus. Similar scan a few weeks later on a Somaton Force. It's better, but it's still reasonably noisy. And on the photon counting system, we actually get a reasonably good image. So we've reduced the noise. You can see the CTDI is a little bit higher as well because it was bumped up by a few percentage because of the size of the patient. But we have some artifacts there around the pelvis because of photon starvation. But essentially, it's a much more improved image. So it just kind of goes to show that the noise can be reduced. Like I said, this is the second one of equal contribution of X-rays. So like I said earlier, if you have your traditional energy integrating detector, there's a down weighting of those lower energy X-rays, which reduces the contrast to noise because low KV is required to boost that iodine signal. With our photon counting system, we have kind of the opposite. We have a fairly stable response with energy. So there's no down weighting of those low energy X-rays, and it uses the full spectrum of X-ray energy at an equal level. And the time for a signal measurement is much smaller, 15 nanoseconds, as opposed to 250 microseconds for the EID. This kind of translates into slightly increased tissue contrasts. You can see there from that example, and also a higher contrast to noise ratio for the same kind of scan compared to standard CT. In this case, it's improved in particular a high KVP, so either 120 or 140, which is what we tend to do most of these photon counting scans at. And of course, with this higher CNR, it allows you to potentially reduce the radiation dose or use less contrast agent as well. This is an example that predates our specific scanner that was released in 2021. So this is an example you can see on the left of energy integrating detector lung scan. And on the right is a photon counting scan. So you can see the kind of improved resolution going from left to right there in those columns. And the kind of summary of this particular paper was a high resolution photon counting detector increased the radiologist's ability to visualize higher order bronchi and bronchial walls without compromising nodule evaluation with current chest CT. Another scan, 74-year-old male, diagnosed with interstitial lung disease consistent with idiopathic nonspecific interstitial pneumonia. I'm not a physician, by the way, so this is from our clinical colleagues. And you can see the resolution here, and the query was, is there reticulation or ground glass opacity? And looking at a photon counting scan, we can see that there isn't any ground glass opacity and just reticulation. So obviously this is a marker for interstitial lung disease. And the confidence of reticulation was increased in 2 readers using photon counting CT. Another scan of post-COVID patient with photon counting CT, you can see the energy integrating standard CT on the left, reasonably okay resolution in the lung. Doing this at high resolution in the photon counting system just shows that you get better resolution. You can see it kind of clears up quite nicely. And if you add some functional information in there, you can see that that particular section of the lung in terms of function is not working. We also, through our clinical collaborators, found this particular example of, sorry, go back a second, of central lobar emphysema that was only seen on photon counting detectors. You can see those 2 arrows there on the right-hand side, as opposed to the exact same location on the left-hand side, where we can't really see anything because of the level of noise in there. So we have improved contrast in there. In the cardiovascular space, we've done a lot of stent imaging. So these are ex vivo stents. So these were scanned within a water phantom, and you can see that using the photon counting system, the resolution is much more improved for the same size stent. The image on the left essentially is 2 stents, such a large stent on the left, which is about 7.5 millimeters, and a smaller one to the right of that, which is 2.5 millimeters. And you can see by varying around with the reconstruction kernel and the slice thickness, which is in brackets, the best resolution clearly is a higher kernel at the very bottom, QR72, and a thinner slice, which is 0.2 millimeters of ultra high resolution. Now that translates in the clinical space to doing the same thing. So we have a case here you can see the distal stent there at the bottom of the LAD, which on the standard resolution scan isn't really diagnostic. So it's a little bit more awkward to tell. Excuse me. It's a little bit more awkward to tell what's going on in there. For this particular patient, the stress echo was normal, so an ICA would be of no real benefit. And essentially that scan will show it as non-diagnostic and probably send the patient off for an ICA anyway. Doing that under high resolution, you can see that the stent is actually patent, and you can see things that are happening within that stent, the ultra high resolution. So this particular case with intima hyperplasia, which essentially is where the intima starts to grow through the stent and essentially potentially restenose the vessel, we can see that there's no ischemia, and then the patient would just be followed up in 1 year's time. Now, another example, looking at increased spatial resolution from our photon counting scan on the right, again, standard CT on the left, we can see that this particular patient would be graded as a CAD-RADS 3, which means they would be sent for functional testing. With our photon counting system on the right, that patient's actually graded as a CAD-RADS 2 and would require no further testing. So this shows that even at the same reconstruction kernel with a thinner slice, better resolution to visualize calcium deposits, we can change the clinical outcome using this particular system. Last one is spectral sensitivity. So that I'm sure some people know already, the principle of spectral CT is essentially to scan something at 2 energies, E1 and E2, and essentially look at the change of X-ray absorption between those 2 energies. And that's what essentially characterizes the material. So this allows you to do things like material decomposition and things like that. Now, the main output for our photon counting system is called virtual monoenergetic images. So for example, we can reconstruct an image at 70 keV, which is equivalent to doing a kVp scan at 120 kVp. So if you think about the mean of where that spectrum would be, it's around about 70, depending on the patient. You can also reconstruct images at 60 keV, 80 keV, 50 keV, 90 keV, whatever we like. Now, essentially what that does is it changes the contrast essentially in the image. So you can see at higher KEVs, things look smaller, essentially for calcium deposits, and at lower energies, they look larger. So there's a bit of debate as to what the best reconstruction is, whereas before with a standard CT, there was just one. So now we have to try decide which one is actually best for physicians to use. We can also do advanced spectral processing algorithms. So this is an example again from MUSC, where we can do some calcium subtraction algorithms. So this is one example where you can see the calcium deposits here, the central image. And we can remove those using a new algorithm called pure lumen. And essentially what that does is it allows you to kind of assess the lumen itself, intermediate grade stenosis, and make a more realistic, clear assessment. Patients with advanced coronary artery disease and a high degree of calcification didn't profit from the advances of non-invasive imaging and had to undergo current gold standard catheter-based angiography. So there's a need to provide more information for these people to guide therapy and give cardiologists more space for treatment interventions, and potentially to reduce the burden for the patient to receive the right diagnosis and improve the assessment of their own individual risk. So essentially, these are the four things I'd like to kind of speak to you today. This is essentially the four things that we would like to promote about photon counting scanning: equal energy contribution, which gives us contrast-rich images; smaller detector pixels, which potentially give higher spatial resolution at the same dose. So there's no dose penalty in using UHR. Intrinsic spectral sensitivity, which gives us multispectral information in every scan. So that's a really key point. We don't need to do a dual energy acquisition anymore. It comes with every single scan. And last but not least, the elimination of electronic noise, which allows us to lower the dose. And we refer to these kind of innovations in one particular system in our Neotom Alpha photon counting CT as quantum technology. So you might see that buzzword floating around in certain places. And finally, thank you for your attention.